The Family Health Podcast is brought to you in partnership with Things Happen, a trusted financial advisor that supports new parents and their families. Things Happen offer the best advice to help parents and their families make informed financial decisions, ensuring a secure and tax-efficient future for their children. The team at Things Happen are highly qualified financial experts who will guide you through the different types of policies to consider as your family expands, taking the stress out of decision making by finding the best deals for your needs, ensuring you and your family are protected no matter how busy life gets. If you already have life insurance, Things Happen will carefully review your existing policy to ensure that it still meets your family's evolving needs, so you know your family is fully protected. Hello, I'm Kate Ball and I'm the founder of Mini First Aid, and welcome to our podcast, Family Health by Mini First Aid. Now, I'm absolutely delighted that you've taken the time to listen to the podcast, because whether you're in the car, cleaning the house or relaxing with a cuppa, our Family Health podcast covers a huge range of topics that might affect one of your family members. And if you've ever got a family health concern and you're thinking, I'm going to Google that, please don't. Please have a listen to us instead. Now, this week, our guest is the wonderful Adelle Fishlock, a consultant paediatric orthopaedic surgeon at Leeds Children's Hospital. Adelle specialises in treating children with neuromuscular disorders and is also, Adelle, a bit of a TV star, having featured on the BBC series Saving Lives in Leeds, which I'm sure you've all avidly watched. I loved it, by the way. I'm a fan. Welcome to the Family Health Podcast, Adelle.
Good morning. Thank you for having me. Thank you for the invite.
No problem. It's great to talk to you. Tell me a little bit, first of all, before we start, about, that was a very impressive job title. I'm going to read it again. Consultant Paediatric Orthopaedic Surgeon. Tell me about this role then. What do you do at Leeds Children's Hospital?
So as you said, I'm one of the consultants there. I work with 6 colleagues. We all work within the Paediatric Orthopaedic department. So everyone, I think, thinks orthopaedics is purely about broken bones, so dealing with children with broken bones, but it's actually a lot more than that. So we have a trauma practice, so that is the acute injury side of things, but we all also have what we call an elective practice. So that's the children that are often referred from a GP with a certain condition. For me, that's treating people and children with neuromuscular problems. So a big proportion of my work is treating children with cerebral palsy. And then a lot of my colleagues will treat children with things like talipes, what was once known as clubfoot, children with dysplasia of the hip. I've even got some crazy colleagues who deal with children with spinal problems, which is obviously a very big, complex subspeciality. I've got colleagues who deal with new evolving areas, so the young adult knee, young adult hip, which is a really new sort of area within paediatric orthopaedics, and then also a colleague that deals with children with bone growth problems, so whether that be related to previous trauma or infection or some kind of congenital problem that they were born with. So he often deals with complex multiple deformities in limbs. All of this is really just trying to improve children's quality of life, helping them mobilise better, helping them with pain. So yeah, it's not all just about the trauma side of things, which I think everyone always thinks it is.
Yeah, me included. I did assume, until when we were prepping for today's conversation, that we were talking just broken bones, but it's a much more rounded, rounded team. Adelle, I can't. Well, I mean, we've borrowed your time for some time this morning, haven't we? And I know you're hugely busy. But I was going to ask you, is there such thing as a typical day? But what does it look like for a day in your working life, Adelle?
It is really varied, and I think that's absolutely one of the reasons why I love it. And one thing to say, I'm quite grateful of this morning. You've got me out of a consultant meeting, so that's always a good thing. So yeah, there isn't really a typical day. It's really very varied. In some ways, I have some structure. So I know one day a week I'll be doing trauma. So that involves a fracture clinic. So that's new patients that are coming in with injuries that don't need to be in hospital and can be treated in an outpatient department. And then I'll be dealing with children with broken bones that need surgery. So that's my trauma side. I then have an elective practice. So I'll have, like today's my elective afternoon. So I have an elective clinic where I'll see patients. I have an elective list, which is an all-day operating list. And then there's the outside, so the on-call commitments. So 1 in 6 weekends, I'll be on call. I'm 1 in 6 evenings overnight. So if there's any emergencies, or if I've got a junior colleague, one of the junior doctors who needs some advice or some help, I'll get a telephone call. And if it's urgent, I'll go into the hospital and operate on these children acutely. Which obviously that can be quite varied, because you don't know what's going to come through the door, what telephone you're going to get at what time of the morning. So that was something it was quite challenging when you first start. You're obviously, every on call you go into, you're quite worried, what am I going to get the next phone call about? But I think as you progress through your career and you start doing more and seeing more, that becomes a little bit easier to deal with. I sleep a little bit better now than I did as my first day as a consultant.
Well, I was going to ask you actually about operating, because we watched you on the telly in surgery, and I've got to confess, it was a bit like sweaty palms just watching it. Tell me how you first felt when you first started doing such significant and important surgery.
It's difficult, isn't it? Because you train for so long. This is what you are trained to do. But suddenly, when your name goes above the bed and everyone looks at you in the team brief, and you haven't got your boss stood next to you, it definitely feels different. I'm really sort of grateful for the sort of training scheme that I've had. I was lucky enough, I trained within the region, so I knew colleagues before I'd even started as a consultant. I did excellent fellowships. I spent 14 months at Sheffield Children's Hospital working with a really good team there. So everything sets you up and you have the skills. But what I found, it's not having them skills, it's sort of how you address things, how you react to things at a certain point in time. Surgery is great when everything's going really well, but when things are not going so well, I think, and suddenly everyone's looking at you, sure. That's when things get challenging, and that's when you really start feeling it. But again, I'm lucky to work in a really supported team at Children's Hospital in Leeds, and there's always someone around. So if you are getting into trouble, or if you feel that things aren't going quite right and you want another pair of eyes, there's other people around. We've got a huge orthopaedic team in Leeds Hospital. We've got, at any one point in time, we have a trauma team on, a general trauma team, us in the peds team, a spinal team. So you're never alone, and that's what you need in a big hospital where you're doing complex cases such as Leeds Children's.
I talked about all that pressure, and we saw you on the telly having to tell families that they weren't going to make a list that particular day, and the pressure that comes with that. But not only did you have to do that, but you had to do that while somebody pointed a television camera in your face, knowing that this was going to go out to millions of people who were interested to learn about you and your role and saving lives in Leeds.
Yeah.
And you look like a total natural. So what's the trick then? What's the trick for maintaining that composure under pressure, just in general, but also then how you do that on the telly?
I think I was really lucky with the team that were in the hospital at that time. For me, it was really important that we really showed everyone and the people watching the programme what it was like to be a patient, what it was like to be part of the team in Leeds. And I wanted the viewers to really get that and to understand that feeling, and to see that we do have that empathy, and it is really difficult, especially when we're cancelling patients. But the team that were with us were absolutely fantastic. I don't know how they did it, but they almost disappeared into the background. I think
Sure.
At the end of the day, I'm there to do a job, and at the front of that is my patient that's in front of me. And whether there's a TV camera pointing at me or not, I'd like to think I act exactly the same as I did on TV, whether or not the team are there. But they were very good at just disappearing into the background, allowing us to do our job, and made me feel quite relaxed. I felt I was just able to be myself on camera, which is exactly what I wanted people to see, really.
And that's definitely how it came across. And one of the things that you spoke about on Saving Lives in Leeds was the fact that your son had surgery at 18 months, tiny. And that was a real turning point for you in your career. Can you tell us a little bit more about that?
Yeah, of course. It really was a turning point. I was actually coming right to the end of my training. So I was sitting my final assessment to sort of complete my training that week. And we got admitted. He presented with hip pain, a temperature, and generally unwell, and all the signs and symptoms of an infection in his hip, which is hard to believe as with his mum wanting and being a paediatric orthopaedic surgeon, that he had all the hallmarks for septic arthritis. So I brought him to Leeds, and I was seen by my friend in A&E, and then he was admitted onto our ward where I work, which was interesting in itself, being on the other side of that, being a parent staying in a bay. And the understanding of what was going on, I found quite difficult. I found that my husband looked to me a lot. We went down to the ultrasound department, and my son had an ultrasound of his hip to see whether there was any fluid in it. And I started crying, seeing on the screen that there was, knowing he was going to go to theatre. And my husband looked at me and thought I was crying happy tears.
Oh,
and he was like, "Oh, so that's good." I was like, "No, that's definitely not good." So I found it hard to be the person to sort of dissociate myself from being the doctor and the mum, because I knew exactly what was happening. I knew what the next step was. I knew we were going to theatre. But actually then being the mum dealing with that is very different to being the doctor on the other side of that. But the feeling of taking your child to theatre is something I think I'll never, ever forget. And I still find it quite hard now, sometimes being in that anaesthetic room when the child is going to sleep, and that emotion. Because effectively you're bringing the most precious thing in the world to you into a room where you're going to walk away. And it was very rare that I'd left my 18-month-old child prior to this. And you're effectively leaving your child with a bunch of strangers. For me, I knew a lot of them, so I didn't have the true feeling of that, but even it found difficult to me, and I knew a lot of the theatre team. So that feeling of leaving your child with this group of people, knowing that they're going to have surgery, I think is difficult. But it also gives me the feeling on the other side of that of how humbling that is as a doctor, that this person, this mother, this father is entrusting their child to you to do the right thing. So it really was a turning point. Before that, I don't think I could understand what it feels like. I think until you stand in them shoes in that anaesthetic room, it's very difficult to understand that. So yeah, it was a real turning point in my career. And as I say, I still have to walk out of the anaesthetic room now when child's going to sleep, because it's
brings
difficult.
It back. Yeah,
it does.
I bet, and I'm nodding along because I've been there in the sense of taking one of my children for surgery, and it's you can't describe it until you've been there. It's one of the reasons that in our last podcast series we spoke to consultant anaesthetist Ed Rotherhurst, because we were talking about the fact that you take your precious baby in for surgery, precious baby of whatever age really, and you have to walk out, and and it's really tough, and and I can see now how that must have had a huge impact for you because of turning the tables on where you sit in that relationship. We all want to know, how is your son now? Is everything
he's
doing okay?
Absolutely fine. To be fair, he was fine the day after. He's been brilliant. He's forgotten about it until actually 2 days ago. He asked me where his scar was, so obviously it hasn't affected him that much. Just me, mentally scarred.
I bet. Well, that's great to hear. That's absolutely great to hear, and lovely in many respects that you were able to do that sort of, or be supported by your team in Leeds. I know we said that, that the nature of your role was not about broken bones, but there are people that have burning questions. We get asked all the time on the Family Health Podcast for people to send us their questions. And I want to pick your brains as a mum, but also as the host. I need to ask you some questions about, for the parents listening, if a parent is out at a park, maybe they've had a nasty fall off a swing, and let's say they suspect that their child's arm is broken, what should they do before they reach the proper medical care to give them the best chance of recovery? What's your advice for that?
So I think the best thing to do is obviously to notice it and to act upon that. I think if you've got serious concerns, so if there's broken skin or there's bleeding or the arm looks deformed, then there's very clear signs there that you need to get medical attention quite urgently. If the arm's a bit swollen but the child's using it, I think you could probably give it half an hour, see if that settles. But if the child's sort of inconsolable, the swelling's there, they're not using a particular limb, I think it's really important that they get attention. The things you can do as a first aid thing is just support the limb. So whether you can make just a sling to support it while you get that attention. Other things you can do is give some simple pain relief, so some paracetamol if the child is struggling, anti-inflammatories if the child is able to take them. But it's really noticing and monitoring them symptoms. And if things are not getting better or they're getting worse, I think it's really important that you get medical attention. It's really difficult for me without an x-ray to tell if a child's got a broken bone or not.
Yeah.
A child with a soft tissue injury will often present very similarly to a child with a broken bone. So until you get that x-ray, you often don't know if there is an underlying fracture. So it's about monitoring, noticing things, and if there is sort of very urgent things that need attention, getting that attention early would be my advice.
Where are we going? Because we're all consumed with the fact that we don't want to be a time waster. We don't want to add to the pressure of the NHS. So are we ringing 999? Do we go to A&E, or are we off to the minor injuries unit? Where are we heading?
So I'd say, obviously, if there's a major injury, so if there's been a road traffic accident or significant injury, then 999 is obviously your first port of call. I'd say if there's any bleeding with associated so if you can see the bone and it's bleeding, then it's a 999 call. If you've had an injury and the child's completely unable to walk, or when they try and walk, there's obviously deformity of their legs, then that's a 999 call. If you suspect a broken bone in the arm looks slightly deformed, or what we talk about as a sort of dynastic deformity, or you look at the arm and it doesn't look like an arm, but there's no bleeding or there's no pins and needles or anything like that, then you could go to A&E. And if your child's had an injury and it's a bit swollen, you've noticed they're not using it so much, you're not sure, is this soft tissue, is this a bony injury, then a minor injuries unit is probably where I'd say. But I think it's often very difficult as a parent, because the first thing to do is, oh my goodness, what do I do? So as long as you are getting some kind of attention and getting reassurance, whether that be reassurance from having an x-ray or reassurance from seeing a medical professional, then I don't think it matters what you do. But obviously significant injury is a 999 call. And if you're not sure and you think this is possibly a soft tissue injury, I'd say minor injuries are fantastic at dealing with them.
Okay. Now, you get to hospital, so you've made the decision to take your child to hospital to A&E. You arrive. Now, I've done this. I've got the T-shirt, so to speak, so I've had that experience. Tell me what happens. You go through the doors of A&E, you register, you say, I'm here, you give your child's details. What happens next for bones?
So with a simple injury, you would obviously be called in. You'd be seen normally by an A&E doctor or an A&E nurse or an A&P. And be assessed. So you'd have a history taken, which is obviously where we try and find out what's happened to you. Hopefully you'd be given some pain relief if we are suffering with pain. You'd have an examination performed, so we'd have a feel around the joint, we'd have a look at it, we'd examine the joint above the injured joint and below that joint, and then we make a decision on what investigations, and depending what type of injury then dictates what investigations we do. Majority of the time for us, that's going to be an x-ray, because that gives us the majority of the answers we need, but we do use other investigations such as ultrasound scans, MRI scans and CT scans, but normally our first line investigation would be an x-ray. If deemed necessary, then the A&E doctor or healthcare professional will call the orthopaedic registrar on call or the SHO on call, depending which hospital you present to, and you'll often be reviewed by them, or they'll give some advice over the phone. And then depending whether it needs surgery, you may well be sent away to come back another day for surgery, or brought into the hospital or given an appropriate treatment. That might be a cast, it might be a splint. So there's often lots of people involved, and it can often take quite a long time.
Yeah, it sounds it. But going back to what you were saying previously about sometimes it's hard to tell whether it's a soft tissue or a joint or a bone injury, until that's what happened with me with one of my children. And I was really concerned because she was guarding and she'd fallen off a trampoline. We're not going to get started on trampolines right now. But she was guarding. And actually, when we went for X-ray, it was okay. It was just a strain, and we just needed to look after it and keep it supported and what have you. And she's fine, but you don't know, do you? Parents don't have X-ray eyes as much as we perhaps would like that superpower.
Oh, it would be.
Imagine if you.
For me, it would be absolute. But it's the same for me. I can examine a child, and I don't know if it's a soft tissue injury or a bone. So the only way is an X-ray, really.
Yeah.
So don't be surprised if the child who comes to us does get an X-ray, and often we children are quite interesting because sometimes you can suspect an injury or a fracture. You do an X-ray and you can't see it, and it might only be 5 to 7 days after that you start seeing X-ray changes. So
Right,
often
okay.
you'd come, you'd have an X-ray, we might still suspect a fracture, and then you'd be sent to fracture clinic where you may then have a follow-up X-ray done, and you're starting to look for little bone changes that suggest healing of a fracture. So in
Okay.
children, we often don't see a true fracture on the first X-ray. It's not till later with follow-up X-rays that we see the injury.
I've heard this, and I've heard of people being called back to come and see the
Yeah,
consultant for this. Right, okay. That makes sense. So it's not that
yeah,
it's been missed, it's
no,
because of where it's presenting. Right, okay, that's really
yeah,
interesting. That's really interesting. Okay. So in an ideal scenario, especially from a first aid background, is that we want to think about prevention as well, because we don't,
yeah.
in these sort of perhaps more preventable injuries, is there things that we can do to avoid children becoming patients of yours, Adelle? What could we do?
I think it's really difficult, that one. And there's simple things that we can do, but no matter what we do, children are going to be children.
Hmm.
And let's be honest, I'm never going to be out of a job. Children are always doing something that is high risk and injuring themselves. And I think it's very difficult to wrap your child in cotton wool. And actually, I really wouldn't advocate that, because bone actually responds to stresses, and bone becomes strong through stressing it. So running, jumping, all these things actually strengthen bone and help reduce the risk of fracture. One of the biggest things I'd say is we know that about 50% of preschool children are deficient on vitamin D, and that has a real impact on bone strength and quality. So vitamin D supplementation, I think, is really important. I
Sure.
say that and then I constantly forget to give my son his. So I know how that feels,
Yeah.
and it is hard to remember, but I do think that's really important. And as you mentioned at the beginning of the show, injury prevention, I think that's a really big thing that we need to be looking at. There's a lot of evidence out there that nearly 40% of injuries can be prevented with a really adequate warm-up, and we're seeing that now coming through at grassroots level sporting, that the warm-ups and injury prevention are a real important factor within the game. And that's really nice to see. I was listening to a podcast myself recently about the injury prevention, and that's the biggest thing with children, I think, is trying to prevent that, especially within grassroots, within different sporting events. But no matter what you do, I think it's sometimes just bad luck. Children will be children. We want children to be happy. Children are happy when they're playing, and you're never going to be able to stop them do that, nor would we want to stop them doing that. You mentioned about trampolines. We've got a trampoline, rightly or wrongly, but it's actually split our consultant body. 50% of us do, 50% of us don't.
Yeah, of course.
My theory is if my son has a trampoline at home, he knows how to use it. When he goes to someone else's house who's got a trampoline, he won't be too excited by it, so won't be going absolutely crazy on it. There's two very different schools of thought, but luckily I know some good people who can fix him if there are any problems.
Absolutely. You know where to go. You've got the fix-it shop on speed dial. Yeah, absolutely. It is a tricky one, isn't it? Because we make
It is.
decisions as a parent, consciously parenting. You make decisions on, what you're going to allow your children to do. And I think, saying children need to be children is really, really important, because you don't want to be driven to this anxiety where they don't get opportunities, or they don't get to play because of fear of accident and what have you. So Adelle, it's been fascinating. It's been absolutely and I'm just in awe of I think, if you haven't, by the way, watched Saving Lives in Leeds and watched Adelle, you need to, because of how calmly you just go into surgery and do these major operations on huge joints in children's bodies. It just seems so calm.
Oh,
Yeah.
it's like being a duck, my leg under the surface.
There we go. That's it. That's the trick. That's the trick. We always ask our guests when they come on the Family Health podcast, if there is one take home for parents or families listening, what would you want people to take away from listening to you talking about your work in orthopaedics today?
That it's stressful, it's busy, but at the end of the day, we have your child's best interest at heart, and we, as a team, I think we're really good at being that patient focused, to understand what it's like for our patients, for our families to go through this, and to be part of that for us I think is really special. And as I said, very humbling that that you go through that experience with your families, and yeah, that they are important to us, and that when we do make these decisions and cancellations happen, that's difficult.
Yeah, Adelle, thank you. It's been an absolutely fascinating. We could talk all morning, couldn't we? But I don't want to keep you any longer from your consultants.
Oh, please
meeting.
do. I don't want to go back to that meeting.
They're all going to go, what's she been doing? That's it. What have you been chatting to us about? Adelle, it's been an absolute pleasure to have you on the Family Health Podcast. Folks, as you're listening, please do subscribe to the Mini First Aid social channels and our newsletter, because this is where we bring you the most up-to-date health and wellness information around a broad range of subjects, including today's orthopaedics. Now, if you want to see what Adelle looks like, if you've not seen enough of her on the telly, you want to see what she looks like today, we do share all of our podcasts on our YouTube channel as well. You can watch it there, and you can download and subscribe to all of our podcasts across your favourite podcast platform. And my final request before I let Adelle go is, if you have any particular topics that you would like us to cover in the future on the Family Health Podcast, please do get in touch. It was Broken Bones that our followers were asking us to talk to you about, Adelle. So thank you so much for coming today. You've been listening to the Family Health Podcast. And just a little reminder from me and our sponsor, Things Happen, that if reviewing your life insurance is still on your to-do list, take time to get in touch with a Things Happen advisor today.